All right, well, welcome to this pharmacology review on the drug class Mineralocorticoid Receptor Antagonists. I'm Dr. Busti, your faculty and host on This Is Why, a show that transforms medical knowledge from what to why. With 30 years of experience as a nurse, pharmacist, physician, and academician, I desire to help healthcare professionals connect the dots to our knowledge, which enables us to see where the evidence meets understanding. And this drug class is a good example of that. Spironolactone in particular really hit big when it was being studied in heart failure as part of the RALES trial. This trial was ended early because the benefits were so obvious to those taking spironolactone that it was considered unethical to continue the trial. It's pretty amazing. And this has been going on for decades. This drug class has slowly expanded. Now, as with everything, right, side effects create opportunity. And that's where this class has evolved. And I expect it probably will continue to some degree. All right. As with all of our pharmacology reviews, it is relevant to keep in mind that this is going to be an overview of the drug class, but I will try to weave in some of those little pearls that allow the evidence to be what it is. And so with that, let's go ahead and get started. So why is it relevant for us to learn about mineralocorticoid receptor antagonist? All right, so first, it improves mortality in heart failure. That's a big deal. Heart failure is a major chronic medical condition that affects patients that we manage in the inpatient and outpatient environment. Now, in part, it does that because of its benefits on cardiac remodeling. Also is a great treatment option for those patients with resistant hypertension or secondary hypertension. And there's one agent in this class that even helps patients with cirrhosis. So it's got a lot of impact, and as I said at the beginning, evidence to support its use. All right, so what medications make up this class? Well, the first is Eplerenone, followed by Finerenone, and then Spironolactone in alphabetical order. Doesn't mean it's the most important or the most commonly used. In fact, Spironolactone has been around the longest. Eplerenone also has some evidence to suggest its use. That was the EPHESUS trial that followed after the RALES trial and was stopped early. And its use in heart failure. And then Finerenone is the kind of newer kid in that group that has been now seeing more growth in application. So based on the relevance and the medications that we just discussed that make up this class, what are some of the indications and or common uses for this drug class? All right. So just like with other drug class reviews, a lot of times when we have a category of medicines, which in this case is the diuretics, I like to look at those drugs in context to other drug classes. Why do we pick one agent over another? Where is their similarities? Where are their differences? Maybe it has a unique. Those end up being great test questions for boards or your classes, but they also are really common bedside questions and have a lot of clinical relevance associated with them. So they're good to highlight, point out some of those things, and I like to try to walk you through that. So this table, which is available at the website thisiswhy.health, is available for you guys, those who have memberships there that are free. You can download it. You can use it for study or share it with friends, colleagues, or students, residents. If you teach, you can use it, right? I mean, the goal is to help you and equip you with some of this information if you find it useful. So over here on the left-hand side, we got the thiazide diuretics. So over here, we have the thiazide diuretics followed by the loop diuretics, and this is our class that we're talking about right now, the mineralocorticoid receptor antagonists. Then we have the potassium sparing, carbonic anhydrase, and then osmotic diuretics towards the end, the least common sort of drug classes utilized. Then you can see that the various columns represent some indications and, again, common uses. That doesn't mean it's everything exhaustive. It doesn't always mean that it's FDA approved, blah, blah, blah. The point is that what are we using these drugs in real-world clinical practice for? And so we've identified those with check marks based on the row and specifically even the drug in that class. So, for example, spironolactone, you can see, is used for the treatment of ascites in patients with underlying cirrhosis. Now, I'm not going to go into the whole reason and mechanism here. We cover that in other episodes or topic reviews that you can check out at the website. But it's a really important drug in that situation. And the reason is that the aldosterone levels are really, really high. And that has a lot to do with the oncotic pressure shifts over time in patients with cirrhosis. But you don't see that with Finerenone or Eplerenone. It's just spironolactone. That's unique. That's a good thing to remember. You see, for example, that heart failure, these agents are all three can be used in the management of this condition. We talked a little bit about that at the very beginning when I talked about spironolactone in the RALES trial in heart failure. I mentioned it with the Eplerenone in the EPHESUS trial. And now Finerenone has sort of joined that group. And I suspect maybe there may be some more growth. But CKD, type 2 diabetes, specifically is Finerenone. And this has to do with one of the things we're going to talk about, the distribution of the receptors for mineralocorticoid receptors in the body and why one drug agent in this class is different from another. There's more selectivity. And that's what we'll start talking about here in a minute. And then next you'll see hypertension. That makes sense, especially secondary hypertension or that resistant hypertension where you're needing to be on 3-4 medications in order to get this patient to their goal. And then lastly, you see over here in the very far end is primary hyperaldosteronism. Well, that makes sense. Part of this drug class name used to be aldosterone antagonists. That was a little easier to say, actually. I kind of preferred it. But mineralocorticoid receptors are present in multiple places. And sometimes people would have thought that aldosterone only works in the kidney, but there are receptors in the heart and other tissues. And that's where the value of things like Finerenone and other drugs can be beneficial, and including even spironolactone has some degree of benefit there because of the modulation of the receptors in those other tissues. So primary hyperaldosteronism, which can cause more resistant hypertension, is a great situation for these drugs because you're blocking really the underlying problem, where some of the other agents are indirect fixes to the problem. All right, the next thing that you see within this indication is dosing considerations. And, some of this is important to recognize because the way we dose a medication in one indication may be different for another. For example, if you look at that spironolactone, which is indicated for ascites in patients with cirrhosis, we're talking about very big and different doses compared to heart failure. Very different. I mean, look at that. Up to 400 milligrams a day of spironolactone for ascites versus heart failure, 50. Very different. Now look at also primary aldosteronism. The adrenal gland is making way too much aldosterone, so the dose needs to be very different. So the indication also impacts the dose of which we titrate the medication to. Now, certainly at those doses, one of the problems with it is that we see potentially more side effects. We'll learn here in more detail that these drugs can cause retention of potassium. Well, if you retain potassium, you can develop hyperkalemia. Too much potassium, just like not enough potassium, can be life-threatening. So we do need to be careful. So sometimes we have to co-administer medications, something like a loop diuretic, to counteract the hyperkalemia, basically force them to get rid of the potassium. So we're adding on a drug to really treat a side effect. But that happens especially when you get to really big doses or when these drugs have drug interactions or are used in patients with renal impairment, which we'll see here in a few minutes. So the indications kind of influence the dose that which we titrate patients to. Now, we know that the relevance, the name of these medicines, their indications, their doses need to correlate or should make sense in the context of the mechanism. The mechanism is where the why really starts to come alive and where everything after that really does make sense. So let's take a moment and let's dive into how do these medications and indications connect with their mechanism. Okay, so now in order to make sense of the mechanism of action, we need to, in this case, and specifically with this drug class, consider some of the anatomical factors that may impact the drug's delivery to the site of action. I don't care what a drug does in a lab, I care what it does in a patient. And so when you administer it IV or by mouth, it has to go somewhere. And in this case, we need to get it to the kidneys, okay? That means one of the ways we get there is by perfusion. So I like to stop for just a quick second and orient to the basic anatomy, especially in the context of blood flow, because it's an essential component to the way the drug works, getting it to its site of action, but also the degree of efficacy that we see and the variations that sometimes come when that blood flow is being altered by some other problem, like say it's like heart failure. Now, Bro, who's one of my old residents, just kidding. Bro, we like Bro. He hangs out with us. He's got glasses. But, you know, we like to use him and take his body parts to teach these points. All right, guys, just kidding. Having a little fun here. The kidneys and the bladder and the ureters anatomically sit in this area. And it's important because this is also where patients exhibit symptoms when they're having problems with their kidneys. The back, that CVA or flank tenderness becomes very real, right? But anatomically, you can also see, even with trauma, why we would be concerned about the kidneys. But look at these blood vessels, where they're coming from. Well, the heart is sitting up here, obviously, and is that cardiac output. 25% of the cardiac output with each beat goes to the kidneys. That's a lot, a fourth. So there's a lot of other parts of this body that need to get perfused, but the kidneys are certainly getting a lot of attention. So we need volume, but we need blood pressure, we need perfusion to those kidneys. So when we start to look at the anatomy, sorry bro, I'm taking your parts here. They're gonna be good use, right? We have the left kidney, the right kidney, we have the inferior vena cava, but we also have the aorta. Remember the ascending aorta curves, aortic arch, and it comes down to the descending aorta. And this is where abdominal aortic aneurysms occur. These can develop weakenings in the wall and that kind of stuff. You see a lot of branches coming off. They go to different organs, the intestines and other things that have been removed here. Then we've got perfusion to the kidneys, okay? You also see that within the kidneys, we have these two things on top. Those are adrenal glands. That's where aldosterone is released. That will also impact the kidneys as another form of a diuretic. It's one of our mineralocorticoids. It helps to retain sodium plus water. Okay? So it can be a reason for secondary hypertension, hyperaldosteronism. You also then see the ureters drain down into the bladder and eventually then would be eliminated. When we look at the kidneys and we take a cross section of the kidney, I'm going to grab a larger version of Bro's kidney here. You see that there are blood vessels coming in and there's blood vessels exiting. Okay. You also see that as those blood vessels go in, they branch down to small vessels. Where are they going? They're trying to get to the nephron, which is what we're getting ready to talk about in more detail. But the drug has got to get to this organ and has got to get inside of this organ down to that nephron in order to have any ability to make an effect and cause a diuresis. Okay? If we get some decent blockage of the transporters in the nephron that we'll talk about here in a minute, then we're going to see more volume coming out, entering into the renal pelvis and down into the ureter. So let's now stop and take a moment and let's dive into the little details right here in this area as it relates to the nephron. So here's a classic nephron down at the tissue level. You can't see it, microscopic, but there's a lot of these present in the kidney. But you see these blood vessels coming in and exiting, and specifically the arteries perfusing that glomerulus. That is where the Bowman's capsule is. This is where a lot of filtration occurs. What is being filtered there? Water, sodium, glucose, bicarb, other things. But a lot of things get filtered there. This is a big filtering membrane to concentrate and help us to regulate electrolytes, water, and fluid balance, which is why when people don't have kidneys, they need an artificial kidney system like dialysis, okay? Now, you also notice that there's the beginning stages. This is the proximal renal tubule right here, okay? Now, as urine filtrate moves to the proximal renal tubule, it will then enter into the loop of Henle. And there's a lot of free water reabsorption going on here, concentration of there's gradients. It's hard to show it all right here, but just understand that it's very detailed. But you see a lot of things that are influencing the urine filtrate, and then it approaches the thick ascending loop of Henle. Then it eventually makes its way to the distal convoluted tubule, and then it makes its way to the collecting duct. Now, the collecting duct is pretty much the last effort for water to be reabsorbed. And so you see a lot of free water being absorbed at this level. This is where urine is being concentrated. So if you're out in the desert and you're sweating or you're doing a lot of manual labor and losing lots of fluids, your body is going to try to hold on to that free water. So it's going to increase antidiuretic hormone and you're going to suck in that free water. Okay? Now, let's go back to the neuron. Approximately 60% of sodium that's filtered into this area is reabsorbed. At the thick ascending loop of Henle, about 20 to 40% of sodium water is being reabsorbed. At the distal convoluted tubule, about 5 to 10% of sodium and water is being reabsorbed. Why does it matter that? Okay, well, it matters because we have drug therapy that targets this area. We have drug therapy, in particular the loops, that target this area. We have drugs like thiazide diuretics, but also potassium-sparing diuretics, and even mineralocorticoid receptor antagonists that start to impact this area. All of those things are working as diuretics from varying degrees for various uses and benefits on minerals and electrolytes to create a desired effect. And that's why we pick an agent or type of diuretic for a specific indication. Okay, so now at this point, we've talked a little bit about the blood flow from a gross anatomy standpoint into the kidney. We've narrowed in to the nephron, looking at that. Let's take a step and get to the glomerulus. And you're like, well, why are you spending so much time on this? Because the drug has to get to the site of action. If it doesn't make it to the kidney for hemodynamic reasons, it's not going to do anything. Once it makes it to the kidney, it still has to get inside of the nephron, the renal tubule. So it has to get moved across cell membranes and put inside of this tubule system. It works on the tubular side, or what is called the apical membrane side of the lumen. Without it getting there, it's not going to work. I don't care what it does in a lab. I care what it does in a real patient. And these things influence, the normal anatomy and physiology influence the way this drug is going to work. It also impacts the way you dose it. It impacts the way we use the drug. Sometimes we give doses intermittently. Sometimes we put them on a continuous drip, IV, for a reason. Those are all the reasons for doing that, the why. goes back to understanding this. So if you can understand why this stuff matters, then those things make sense. All right, now let's dive into the glomerulus. So here we are, again, we're zoomed in this very small area of the kidney, specifically looking at the nephron, and we're right here where that renal afferent arteriole is coming in. So remember, 25% of our cardiac output in normal situations, under normal conditions, is roughly going to the kidneys. That means that the kidneys are important for a reason. So we have blood vessels coming in to the glomerulus. Those are called renal afferent arterioles under the influence of a number of chemical mediators that are endogenously made. Things like the sympathetic nervous system, angiotensin II, prostaglandins, bradykinin, nitric oxide. All those things influence the diameter or the level of constriction that regulate blood flow coming into the glomerulus that then impact the overall glomerular filtration pressures generated. Why does that matter? Because pressure is going to push things into the Bowman's capsular space. This is where the earliest stages of urine filtrate are made. This is also where things like sodium, water, glucose, bicarb, like I said before, get put in here. So they dump into this area. Now the drugs, like loop diuretics, are not put in there like that. They have to make it on and go into the efferent arterioles and enter the peritubular capillary blood vessel network, which is close to the nephron. But we need the drug inside of the nephron tube. So this is where drugs, and there's a lot of drugs that get put in here, a lot of chemicals, even like uric acid and beta-lactam antibiotics, things like that, they get put into the kidneys for elimination. Okay, well in this case, we got to get it in the kidneys to work. So the loop diuretic. So this blood flow through here and this presence of that is essential for the drugs to work. So you can imagine if we take away nephrons or we reduce the blood flow into the kidney, we're going to therefore reduce the efficacy of the loop diuretic. I mean, it's not rocket science. It makes sense, right? So let's now move into the proximal renal tubule and see what's going on about getting that drug in the space. I know this is a lot to absorb when you first see it, like, oh my goodness, Dr. Busti, like, what are you showing me? I don't need a seizure right now. There is a lot going on in the proximal renal tubule. I'm not even doing full justice to it. Just going to say that right now. There are a lot of other transporters, influx, efflux transporters, changes in the permeability, all these things happening. There's a lot going on in that proximal renal tubule. Remember, that's where the earliest stage of the renal urine filtrate is being made and starting to be formulated in its final form. So very early on, sodium is important, which was, remember, part of the filtrate. Water is very important for a number of reasons, okay? Glucose is being reabsorbed, especially if you can, not too high, right? This is where patients with diabetes suffer from polyuria, polydipsia. They spill too much glucose, and the sodium glucose transporters, SGLT2 transporters, cannot absorb enough. Right? Typically, when you get over 180 milligrams per deciliter, they just can't do it, so it just spills out. All right, but we've got efflux transporters, uric acid transporters, all this stuff. Well, let me orient you to the proximal renal tubule. So there's early cells in the proximal renal tubule, and then there's late. You're like, okay, why does that matter? It matters because the distribution of transporters shifts as you go down in the nephron. It's going to change when you get to the ascending loop of Henle. They're not all the same in all locations. It has to do with that purpose of that geographic location. So that's one of the reasons why I mentioned that. Number two is, remember, you see that we have the lumen or tubular side, and there's the apical membrane on the tubular side. Then there's the interstitial space, or where the blood vessels, that peritubular capillary network system, is on the basolateral side, if you will. So remember that the loop diuretic is coming in from the efferent arteriole, and here it is. Well, it's got to get over here. Well, it does that through these transporters that are influx and efflux cell membrane transporters that move things across cell membranes that can't just diffuse for charge reasons, size, whatever. Right? It's complex. And again, like I said, I'm not covering all of it. I'm just giving you a snapshot of some of the key points. That's it for this purpose of this lecture. But you've got to get the drug in through the cell and into the renal tubule as part of the ultimate renal filtrate. Now remember, this is the proximal renal tubule. So now we need to head into the loop of Henle. But before we do that, I want you to recognize that uric acid is also over here. Uric acid also uses some of these pathways, and sometimes there's like traffic jams. They compete, block each other. And so you can raise the concentrations of uric acid or change them. And so that can sometimes be important for patients with underlying gout, for example. Okay, let's now move on to the next step. So here we have the urine filtrate. Here we just left the proximal renal tubule. We now enter the descending loop of Henle. Now we're entering the ascending loop of Henle, and we're now approaching the thick ascending loop of Henle, which is right here. So the urine filtrate is coming in. The loop diuretic is with it. Boom. Here is the transporter that the loop diuretics are focused on. So they work on the ascending loop of Henle, the thick ascending loop of Henle. They work on the sodium, potassium, 2-chloride transporter. Some people use the word cope transporter, those kind of things. But the point of the matter is this thing does a lot. It's moving all these charged molecules across cell membranes. And then you see we have on the basolateral side other membrane permeability shifts or transporters like the sodium potassium ATPase pump that are now going to keep moving again. Remember, 20 to 40% of the reabsorption of sodium right here occurs at this level. So if we block this, then we theoretically can block up to 20 to 40% of sodium reabsorption. Well, what follows sodium? Water. So now that sodium stays in the tubule and the urine filtrate, and is going to now make its way up towards the distal convoluted tubule. We'll talk about that in a second. Now, you see that there's also the ability to block reabsorption of potassium. Well, this is why you can lose potassium. You can also block chloride. This is where sometimes acid-base disturbances eventually come with too much use. You can certainly lose sodium and develop some degree of hyponatremia. But you also see there is some other cations, divalent cations in particular, the magnesium, calcium over here, that are being reabsorbed in a paracellular manner. Well, what does that mean? Well, remember, these are charged. You see all these charges shifting around? Well, that creates a difference on one side of the membrane over the other. And part of the system wants to do is keep things somewhat degree in balance. And so when you change the positives, the negatives do something different, and vice versa. So when you give patients a loop diuretic and you block this, you also block some of the paracellular reabsorption of magnesium and calcium. And so why does that matter? Why do you need to know that? Well, there are additional electrolytes, by the way. Sodium, potassium, calcium, magnesium, all play very critical roles into cardiac function, including intervals on an EKG. If you decrease all of those electrolytes, you can prolong and start to widen the QRS and prolong the QT interval and set these patients up for torsades. So if you remember, like the treatment of torsades is magnesium. So any of those electrolytes in low concentrations can prolong the QT interval and increase the risk of life-threatening dysrhythmias. So that's why it matters. But it also matters for another why. When you start to lose that potassium and you're losing magnesium, you create a bad pattern. You need magnesium at the cellular level to regulate the intracellular concentrations, and i.e. total body potassium levels. You need that magnesium to do that. So without the magnesium, you cannot fix and regulate the total body potassium concentrations inside and outside of the cells. That's very relevant. Why? Because if you just check the potassium and you see, oh, the patient's on a loop diuretic, their potassium is going low because I'm making them urinate it out, I'll just give them more potassium, and you don't bother checking the magnesium, you will not find that you'll have a very hard time correcting the hypokalemia. In order to fix the potassium losses, you have to first fix magnesium losses if they're present. Well, the problem with magnesium is it's not part of a basic metabolic profile. It's not part of a comprehensive metabolic profile. You have to order it separately, and most people don't do it. I can't tell you how many people I find, and I practice in the emergency department, who come in and have hypokalemia, and I check it. They're always seem to be deficient in magnesium. So it's very relevant for you to do that, not only for cardiac-related issues, but it's good. You need magnesium in other places of your body. You need calcium in other places of the body as well. So calcium can be lost as well. Well, why does that matter? Well, that matters because some patients who develop hypercalcemia, specifically we see this in cancer patients where bone is metastasized, or as cancer is metastasized to the bone, and it causes this resorption and this spilling out of calcium into the blood. People want to get rid of that calcium. Well, that makes sense. You don't want it calcifying everywhere. But the treatment is high dose or use of lots of IV fluids. Well, I can also get rid of some of it by using a diuretic like loop diuretic. And because you can get rid of the calcium here, the problem with that is it's not the right way to deal with it, the problem. You need to deal with the metastasis to the bone and the bone resorption, usually with the bisphosphonate, but fluids. Now, we may have to give loop diuretics in that case to get rid of the fluid because we don't want it to start accumulating in their lungs. That's a lot, right? You can see that these drugs have a really good diuretic effect, but boy, they can cause some issues, and that's why sometimes there are nuances in how we use the drugs in clinical practice. When you understand that why, it makes sense of the how to do it and use it. Now, as we go into the distal convoluted tubule, remember what's happening to the urine filtrate right here. It just passed the ascending loop of Henle. It's got a lot of sodium and water. So as it comes up here, the distal convoluted tubule cells over here go, whoa. There's a lot of potassium or sodium coming in the tubule here. Is that normal? Or hey, whoa, what's up, guys? Let's get some of that stuff in. Well, remember, the normal is that, that 5 to 10%. So this is not a big location for a lot of sodium reabsorption. Remember, you're just trying to fix the final urine filtrate before it enters the collecting duct. So that's why thiazides tend to have a more mild diuretic effect compared to the loops. They're blocking that sodium chloride, not potassium, sodium chloride symporter or co-transporter. There's no potassium here. Now you can still lose potassium. That has more to do with shifts over here on this side. And then also distal, there's another effect I'll show you here. We turn the corner. So now it comes over here and it makes its way out. But as I was saying earlier, when you take chronic loop diuretics and you keep delivering all that concentration to that distal convoluted tubule, you run the risk of causing diuretic resistance with chronic use. That means you might have to increase the dose over time to overcome compensatory changes in this tissue of the apical membrane. What that means by compensatory changes, you might upregulate more sodium, chloride, co-transporters. Well, if there's more there, then you're maybe reabsorbing more than 5 to 10%. Maybe it's 15, 20%. And so you start to lose the diuretic effect on the standard dose that had worked before. That's a pharmacodynamic impact. That's like tolerance, if you will, right? So we call it diuretic resistance, but it's kind of this compensatory tolerance you develop, so you have to increase the dose. Or you have to do something to block this transporter from working. And that's why some people would administer selectively, very carefully, a thiazide on top of a loop temporarily to get rid of fluid. You don't want to do that too much because you can over-diurese the patient, but it's very relevant in the context of diuretic resistance. Now let's make our way over to this last little step before they enter the collecting duct. All right, so we have the distal convoluted tubule. It's headed right towards the collecting duct. And there's this last little ditch effort here for us to regulate sodium and potassium. This is somewhat under the influence of aldosterone, which is our mineralocorticoid receptor, or mineralocorticoid. It turns on genes that regulate some of the changes in permeability and reabsorption of sodium here. This is also where free water is starting to be reabsorbed and concentrating the urine, especially if we're needing to hold on to it. So these are your last ditch efforts before you enter into the collecting duct, where mainly it's just urine filtrate concentration that is occurring. So loop diuretics, you're going to see a lot more sodium and water being delivered. That means it'll make its way into the ureter. Now, with all diuretics, you're losing volume. Some are going to cause it more than others, but you're losing volume. Volume is reflective by preload. That's one of the hemodynamic parameters that regulates our blood pressure. So let's take a moment to look at the formula of blood pressure so you can see why the use of these drugs, especially given IV push too rapidly, can sometimes cause hemodynamic shifts in the patient. All right, so blood pressure up here equals the cardiac output times the systemic vascular resistance, or sometimes we refer to that as peripheral vascular resistance. It's the same thing. Now, cardiac output is equal to heart rate times the stroke volume. So if cardiac output is to stay the same, but one of these variables changes, the other one has to compensate. It's just a mathematical equation, that's all it is. But stroke volume is influenced by that preload. That's the volume, force of contraction, or inotropy. And then the afterload, or that resistance to forward flow. But resistance. So diuretics over here all decrease the preload. So as you decrease the preload, you decrease the stroke volume, you decrease cardiac output. That can, especially when administered rapidly, mainly IV push, can cause hemodynamic instability. When you administer it by mouth, yes, of course, you're going to lose plasma volume over time. You're going to diurese the patient. Your preload can go down. And your stroke volume will go down. That will decrease your blood pressure. That is why, and we remember back from the indications that this drug class was initially used in part to manage blood pressure, because you're impacting the blood pressure. Okay, so that's the main mechanisms, and those are the things that should start to, form some thought process together as to the next steps of things you need to do clinically. Okay, so mechanisms make sense of indications, but we have to get the drugs delivered and we need to use them correctly. You heard me talk about the location of receptors. I mentioned the word selectivity of receptors and their distribution in the tissues, those kind of things. And that all impacts the way we use these drugs and some of the indications. So let's dive into some of those things. And I've tried to put together for you some of these in a nutshell as a table. All right. So you can see here on the left side of the screen, we have obviously our medications. We have Spironolactone, Eplerenone, and Finerenone. And you see that Finerenone is labeled as a non-steroidal mineralocorticoid receptor antagonist, MRA. You also see that spironolactone and eplerenone are steroidal. That's a chemical structure thing. I'm going to show you those here in just a second. And you're like, no thanks. I mean, it just explains why we see different selectivity. You don't need to memorize the chemical structure, but it allows you to see the difference. So we have steroidal MRAs and we have non-steroidal MRA right now. And then what's different about them is their distribution. What selectivity of receptors do they preferentially like to bind to? And that's where our pharmacodynamic effect is impacted. So now if you look in the table, you see there's a pharmacokinetic side, and then there's also a pharmacodynamic side. So pharmacokinetic, pharmacodynamic, okay? So on the sort of the left side there, the pharmacokinetic, we see that the oral bioavailability is not too bad, although Finerenone, most of it is not absorbed, only 44%. You see that the distribution is different. So absorption, distribution, metabolism, elimination. When we think about distribution, the spironolactone is preferential to the kidney. 6-fold difference than the heart. Now remember, spironolactone was part of the RALES trial. That was a heart failure trial. And it still showed such a big benefit it had to be stopped early. So when you compare it to eplerenone, eplerenone has more selectivity to the heart, 3-fold difference than the kidney. And then Finerenone and is equal kidney and heart, almost 1-to-1. Okay, again, nothing exact, perfect, but you get the point. They all get into the central nervous system as another distribution. But that distribution is in part influenced by the selectivity of the mineralocorticoid receptor that it's interacting with. So if you look at that and the pharmacodynamic side for just a second, you see that spironolactone has the low selectivity, eplerenone is more selective, and Finerenone is even more selective. So why does that matter? Well, one, it has to do with the distribution. It explains the distribution a little bit, but it actually extends into the side effect profile. One is drugs that work more in the kidney are going to have a greater risk of hyperkalemia because it's working in that kidney, that area where that sodium, water, and potassium distribution is being modulated. So that's a big deal. So the more selective to the kidney, theoretically, the more greater chance of accumulation of potassium. The steroidal versus non-steroidal and selectivity has to do with side effects, and one of them is gynecomastia, basically a tissue and an enlargement of the breast tissue that can be actually painful, especially in men. So there's cosmetic issues, there's self-esteem issues, there's just quality of life issues, and spironolactone, with its lowest specificity and also distribution and being a steroid MRA, is more likely to interact or antagonize some of the androgens that help male in particular characteristics. So that is why the eplerenone causes less gynecomastia than spironolactone. It's also why Finerenone causes it less than spironolactone. It's also why there's a difference in the risk of hyperkalemia between the agents. So I hope that makes sense and explains why you see that side effect profile variation, but also even the indications. Because if you look at the kidney, and I mentioned patients with CKD and type 2 diabetes, that's Finerenone, right? And you might go, well, wait a minute, why not these? Well, they're not being studied to go after that FDA-approved indication necessarily. So some drugs come to market for a unique indication, specificity, its use, and some drugs just don't bother to go do it because they went generic or whatever. No one's going to pay for it. It's not worth studying. Doesn't mean it won't help those patients. It just means there's not the studies to get an FDA-approved indication. Now, what about metabolism? This is a big deal right here. Okay, circle, highlight, star. Remember, these drugs do go through phase 1 metabolic pathway. So the cytochrome P450 system is very relevant because they use 3A4, which is one of the most common substrate pathways for drugs to be metabolized via phase 1 metabolism. There are also a lot of drugs that inhibit and can compete in that same pathway. That can lead to clinically relevant drug interactions. Why does that matter? Well, the risk of side effects and the risk of hyperkalemia is a dose or concentration dependent effect. So if you block the metabolism, you raise the concentrations of the blood, your risk of hyperkalemia naturally go up. And there's a lot of drugs that can do that and inhibit it. So it's very relevant in that context. Now, spironolactone is interestingly also a prodrug. And so it gets metabolized to the active form. So it needs a functional pathway in order to exert its pharmacologic or pharmacodynamic effect. Whew, that's a lot, right? Now, what about affinity and potency to the mineralocorticoid receptor? We talked about selectivity. What about affinity? Well, you can see that Finerenone is really high. So it may not have a very long half-life, but once it binds to that receptor, it's bound to it pretty tight. Whereas Eplerenone, spironolactone, they're also high. Spironolactone's high and Eplerenone's a little bit low. So you see these variations, and that based on their duration of action and some of these things, that gives those subtle variations to why we see what we see. That also influences a little bit of the anti-fibrotic effects. So this, you can see a lot of anti-fibrotic effect with Finerenone compared to spironolactone. Now, what is the extra plus sign? It's just an identifier to try to, again, correlate to the affinity, selectivity, and why that drug class is probably being beneficial while also lowering the risk of certain side effects. Now, what about blood pressure lowering effects? Well, those that tend to have a little bit more selectivity in the kidney are going to have a little bit better effect on that, but it comes at the risk of hyperkalemia. So the hyperkalemia is the kidney focus. It's also related to the selectivity. It's also related to the affinity to the mineralocorticoid and the receptor. So spironolactone having the highest affinity, being a nonsteroidal and more distributed to the kidneys, makes it a higher risk of hyperkalemia. Now, sexual side effects, being things like libido and stuff like that, are impacted because of the blocking of those androgens by the medication. So the steroidal agents are more likely to do that, even Eplerenone. But again, it's less because of modifications in its chemical structure, which I'm going to show you here, that change the binding affinity. So that affinity is not as strong to those androgen receptors, so that we're not seeing that negative effect. And of course, you can see that being a non-steroidal agent structurally improves those side effects in particular. So here's a diagram representing the various chemical structures. Again, I'm not suggesting that you need to memorize this, but what it explains or allows you to wrap your mind around is why there's a variation. So structurally, you have your steroidal agents over here. That's your spironolactone and Eplerenone. And then you have your non-steroidal agents over here. That's your Finerenone. And you can see where the steroidal structure is primarily different. Okay? You can see that there. It's where the difference is occurring. You also see variations in functional groups, like this carboxymethoxy group and the 9,11 epoxide group that's present on Eplerenone. What is that doing as a steroidal structure? Well, it creates hindrance, steric hindrance. It creates crowding, if you will, that prevents it from binding to those receptors. That's why it has a lower binding affinity for those androgen receptors. That reduces the side effects. It doesn't eliminate them. It just reduces them compared to spironolactone. So functional groups and modification of chemical structure can influence where the drug binds, how well it binds, and to what degree of clinical effect that we get, but also the risk of side effects. That's why people and medicinal chemists are manipulating these molecules to try to maximize the desired effect and minimize the undesired effect. That's the goal. But this is where some of the stuff really kind of comes alive. And again, we make these available at thisiswhy.health for you. Okay, so we started to talk a little bit about drug interactions because of the metabolism of these agents through phase 1 metabolic pathways, in particular as substrates of cytochrome P450 3A4. Well, so what are some of these concerns that we have for that? Well, one is side effects, because they can be dose or concentration dependent. I alluded to that earlier when I was talking about ascites. And I talked earlier about what is the dose for ascites? What is the dose titration to for a patient with primary hyperaldosteronism? Very big doses. Well, what happens at those higher doses? More side effects. So whether you're administering or ordering or prescribing the dose at a higher level, or you've caused a drug interaction to increase the concentrations at a higher level, what are you at risk of? Well, one is the hyperkalemia. And then the secondary, and that can be very significant, so much so that we have to start another medication. Again, that's why we use a loop diuretic in context with someone on spironolactone. Typically, that's about, for every 100 milligrams of spironolactone you give, we give about 40 milligrams of Lasix to get rid of that potassium. That's a general rule. You're going to have to modify it and adjust it, but it's a general approach. So hyperkalemia is a big deal, especially if you're administering it with other medications that are known to cause hyperkalemia. Things like ACE inhibitors, angiotensin receptor blockers. I don't know why you'd use a potassium-sparing diuretic, but theoretically, I guess that could happen, right? So we have to keep those things in mind. The gynecomastia is related to that structure and its binding affinities, especially as a steroid. So spironolactone has a high affinity, strong affinity, and it sticks around a long time, and so it's more likely to cause gynecomastia as a steroidal agent. Finerenone has strong affinity, but remember, it's not a steroid. It's not blocking those androgens from doing what they are supposed to do. So what are some of the drug interactions that we would need to be considering of in clinical practice? Well, anything that inhibits 3A4 is a problem. Classic drugs that are known to do that. Protease inhibitors for the treatment of HIV. Drugs, certain antifungal agents that make up the azole antifungal drugs, like itraconazole, posaconazole, ketoconazole, those agents. How about cardiovascular drugs that these patients might also be on if they're on a mineralocorticoid receptor antagonist? Amiodarone, diltiazem, verapamil, very well-known classic inhibitors of phase 1 metabolic pathways, in particular 3A4. I already mentioned ACE inhibitors, ARBs, to you, and the risk in context of developing hyperkalemia. Remember, mineralocorticoid receptor antagonists are going to cause the retention of potassium, especially spironolactone. So if you mix it with drugs that are also known to do that, then the risk just gets more compounded. NSAIDs can counteract some of these drugs. Why? Because they can, remember, regulate and modulate the activity of prostaglandins in that renal afferent arteriole of the glomerulus. That can turn on and influence the amount of renin released. Well, renin release causes RAS activation, and the end result of RAS is more release of aldosterone. So you can counteract the effect of these drugs, including ACE inhibitors and ARBs, by giving somebody an ACE inhibitor. And so those become very relevant in the overall management of patients and are worth doing medication use evaluations on. So now that we have reviewed the side effects, drug interactions, mechanisms, indications, and you see a pattern, you should be able to predict what your monitoring parameters are going to be. You shouldn't have to memorize them. It should make sense. So we know these drugs affect sodium water reabsorption, that affects plasma volume. They're indicated for resistant hypertension. So one of the monitoring parameters should be paying attention to the blood pressure, especially if you are administering and prescribing these drugs for the very purpose of resistant hypertension. Second would be labs. I mean, we've been talking about potassium like crazy. You want to check that potassium, especially in patients on other drugs that may be interacting, or as the kidney function goes down, the risk of hyperkalemia goes up. The number one electrolyte abnormality in patients who come into the hospital or show up to dialysis are CKD patients, and they have hyperkalemia. They also have acid-base disturbances, but hyperkalemia is a big problem. And it's one of the first things that we check and consider, and how acutely or how quickly do we need to dialyze patients. Now, you may need to monitor other symptoms and other physical exam things like gynecomastia and talk to your patient about it. They may be embarrassed. It's not something they're going to bring up. If we don't even alert them to it, they may think something's wrong. They may spend hundreds of thousands of dollars trying to figure out what's going on, get exposed to imaging studies and other stuff that's unnecessary. So it is our responsibility to make sure that patients are informed of these things so they can alert us to either they can't stand it or it's causing physical characteristic changes enough that it impacts them. I would also include sexual changes in that. If they're especially on spironolactone is where that becomes most relevant. So, what are some other counseling points that we should really make sure are directed at our patients so that they're empowered to take control of this situation? Well, first is do not ignore the salt substitute issue. I mentioned a little while ago that when you replace sodium for something, you usually are putting potassium there. Well, we already have a problem with potassium. So they may be thinking they're doing something good for themselves. They're reducing their sodium intake. That's going to impact their blood pressure, their plasma volume, all these good things. But yet, actually, that's detrimental to them. So I'm not saying they can't ever do it, but you need to watch it very closely, especially if they're on multiple medications that are known for causing hyperkalemia. And that becomes really relevant in the heart failure patient. Why? Well, because ACE inhibitors and ARBs are used very early on in the staging of heart failure. Well, when you add on a mineralocorticoid receptor antagonist like spironolactone or eplerenone, it's typically in more class C, stage 3 heart failure when they're already on an ACE inhibitor. So you got two drugs. So now your risk is really going up. And that's just some of the reasons why sometimes patients can't even get added this class of drugs to the regimen, is because of the risk of hyperkalemia. So they need to be educated about that, and they need to be careful, or you can monitor for it. Secondarily, they need to be told that if they get started on other medications by other healthcare providers, and that other healthcare provider is not paying attention, you need to alert them that they need to tell them that they're on a medication that is subject to a lot of drug interactions and cause side effects. Now, if they don't understand it, then tell the patient to call a pharmacist or reach out to you. They need to be making sure they're informed to alert you if or when these things start to happen. Wow. Knowing the why can better equip us to provide personalized and evidence-based care. I mean, this drug class is a great reminder of that, because these drugs not only have the good evidence to support reductions in mortality, especially in heart failure, but we need to be using drugs that have proven benefit when it's appropriate. But there you can see there's some issues that may cloud or disrupt our ability to do that. So this stuff matters. And I know it can sometimes feel overwhelming, but I'm proud of you guys for, those of you that are listening to this and participating in advancing your knowledge or reminding yourself of some of these key or core concepts. I mean, no one can know everything, so we all need to be engaged in helping each other out. And I hope that some of this information that I provided you has been helpful. And we have other things available at thisiswhy.health. put together collections, playlists, various ways so you can study, engage in content. Please check it out. Get access to some of these images that we used in this topic review here, as well as sign up to get newsletters and updates for future topics. All right, guys, mineralocorticoid receptor antagonists have been evolving over the past 3 decades. Newer agents have improved not only some of those side effects, but also have expanded some of the indications that we use. Now remember, spironolactone is slightly different than Eplerenone and Finerenone, and mainly its use in ascites. There's also differences in the structure. Spironolactone and Eplerenone are steroid MRAs, whereas Finerenone is a non-steroid MRA. We got risk of side effects, particular hyperkalemia, gynecomastia, sexual side effects, especially with those steroidal non-selective agents. Drug-drug interactions through phase 1, 3A4. Don't forget that. All right, guys, keep learning fun and keep learning to understand why, because when you know that, you know how to manage patients more effectively. We'll see you next time.